the anatomy of a child, also called as pediatric anatomy. There are some structures in the body, like internal ear, even in a newborn is the same adult size as at birth. Whereas some other are yet to develop. Corticospinal tract is a myelinated tract. Before the myelination occurs, the tract is still there, but it can't transmit impulses. Those tracts which are designed to be myelinated will function only after being myelinated. Those which are designed to remain unmyelinated will function even otherwise. Teeth start erupting at 6 months after birth. Secondary sexual characteristics may take up to puberty. The distinctly different structure in a child versus an adult is the position of the larynx. The laryngeal inlet lies at the level of soft palate in a newborn, which gets further risen up when the child swallows. So child will not choke if he is breathing and swallowing at the same time. This is what makes it different from adults. We have got a common oropharynx through which food and air both passes. If you try to speak while swallowing, the chances are that the different structure will enter the wrong passage. So you don't have to really worry that a newborn child is drinking milk at a supine position. It's not going to choke up in whatever position the newborn is drinking. This position of the larynx descends down at around 1 to 2 years of age. While it is descending down, the fibers of soft palate which are going around the larynx, the palatopharyngeal muscle, which was originally horizontal, now becomes vertical. So it descends down palatopharyngeus. But few fibers of palatopharyngeus remain in that same horizontal plane even after the larynx is descended down. In children born with cleft palate, the food is entering the respiratory passage. So these horizontal fibers of palatopharyngeus goes into strong contraction and we see the thick ridge on the posterior pharyngeal wall. This is called as Passavan's ridge. At the beginning, after birth, there are 3 dramatic circulatory changes. Because the umbilicus is no longer functioning, the closure of umbilical vein occurs, the left umbilical vein, which was left behind. This umbilical vein will become the ligamentum teres hepatis. Then, this umbilical vein was entering the liver and passing through a thoroughfare channel to join the inferior vena cava without its oxygen being consumed by the liver itself. That passage is called as ductus venosus. Ductus venosus obviously now has no function, so that closes. The blood from inferior vena cava and superior vena cava enter the right atrium. Earlier, the superior vena cava oxygenated blood was shunting to the left atrium, passing through foramen ovale in the wall of the interatrial septum. The moment the lungs, the child takes the first breath, pulmonary circulation, volume has increased, pressure has dropped. A large amount of blood will enter the left atrium through the lungs. When the large amount of blood enters the left atrium, the foramen ovale closes. Foramen ovale is like a flap valve, which when there is blood, higher pressure in the right atrium, blood will flow from right to left. Higher pressure in the left atrium, it will attempt to go from left to right, but the flap valve closes. In the child, in the fetal life, the pulmonary trunk, left branch of pulmonary trunk, was joining the arch of aorta, approximately at the site at which the left subclavian vein artery is given off. So that passage of blood is called as ductus arteriosus. In the fetal life, because the lungs are not functioning, the blood will flow from pulmonary to aorta to go into the systemic circulation. Immediately after birth, the pressure of the aorta is greater than that of the lungs because the pulmonary pressure has dropped. So automatically blood will start flowing from aorta to pulmonary trunk. The maximum saturation of placenta is 80 milligram mercury, 80% of saturation. In lungs, the saturation is 100%. So automatically the higher saturation of blood, the moment it enters ductus arteriosus, now from aorta to pulmonary, will cause the tunica media of the ductus arteriosus to go into spasm. So as long as the oxygen saturation is 80, the ductus arteriosus remains patent. The moment the saturation remains becomes 100, the tunica media will go into spasm. That causes the closure of ductus arteriosus. This closure is temporary, but eventually it will become fibrous cord at around 3 weeks of age. That is called as ductus arteriosus, ligament of arteriosus. So these are the three changes. And this ductus arteriosus, as we said, has a specialized tunica media. It has no internal lasic lamina. It cannot restore back to its original size. And at times this specialized tunica media may enter the arch of aorta. And when this ductus arteriosus closes, aorta will also approximate to close, attempt to close, which is called as coarctation of aorta. General features is that the newborn has no neck. No neck because chin is in contact with the chest. Abdomen is pot belly, not at birth but a little after birth. That's because of large liver. Pelvis is shallow. Because the pelvis is shallow, a lot of pelvic organs are abdominal pelvic. Especially even an empty bladder is abdominal pelvic. The limbs are disproportionately developed. The upper limb developed more than the lower limb. Allometric growth in contrast to isometric growth. When you talk about isometric growth, it means uniform growth all over the body. Here it is a different size than growth. You can see that initially in the intrauterine life, the head is 3/8 that of the body. The same in an adult is 1/8 that of the body. Vertical diameter of the head is 3/8 in a child and 1/8 in an adult. If you notice here, the newborn is on the left side, where the vertical diameter of the head, the brain, occupies nearly the same size as that of adult. So forehead is of the same size. Look at the facial skeleton. On the left side, the orbit is 1/2 that of facial skeleton. The total vertical diameter of the orbit and the vertical diameter of maxilla mandible put together is the same. Whereas in an adult, the orbit is only 1/3 that of the face. Because maxilla and mandible are developed. Next slide. At the junction of frontal and parietal bone, there is a anterior frontal, parietal and lambdoid occipital bone is the posterior frontal, and the anterolateral and posterolateral corners of parietal bone. There are anterolateral and posterolateral fontanelles. What is the role, function of the fontanelles? Two functions. One, molding of the skull during childbirth. Two, allowing the growth of the brain. The posterior fontanelle closes at around 2 to 3 months after birth, and anterolateral and posterolateral around 6 to 9 months. So probably their role is for molding of the head. Anterior fontanelle closes by 18 to 24 months. So that is what is allowing the brain to grow. Maximum brain growth occurs in the first 2 years after birth. And two, clinical anatomy of anterior fontanelle. You can pass from the corners of the anterior fontanelle through a needle prick and reach the lateral ventricle. If you want to collect ventricular blood for whatever reason, you can go from the anterolateral corners of the fontanelle. You can also collect dural venous sinus blood if required through the center of the anterior fontanelle, where superior cerebral sinus is located. Two, surgical application. No, two clinical application would be sunken fontanelle means dehydration of the baby. Raised fontanelle means raised intracranial pressure. So remember 2 plus 2 plus 2. Two functions, molding of the skull and growth of brain. Two clinical application, sunken fontanelle and bulging fontanelle. And two surgical application, correction of ventricular CSF, correction of dural venous sinus. Next slide. The temporal bone and the ear is very distinct. The tympanic part is present at birth as a C-shaped tympanic ring. Tympanic part of temporal bone is the bone which forms the lower part of the bony external auditory metal. It's just in the form of a ring. Then from there it grows more rapidly, initially anteriorly, then posteriorly. And where the two join, anterior and posterior growth, there may be sometimes a foramen of Muschke, which is also called as foramen tympani. The tympanic membrane in a child faces more downwards. That's why when you're trying to visualize the tympanic membrane in a child, you pull down the ear pinna so that you can see the tympanic membrane is sloping more downwards. The mastoid antrum, mastoid is not developed, but the mastoid antrum is put at its size at birth. And it's a distance of 3 millimeters from the mitral bone in the suprameatal triangle, the McEwen's triangle. Every year it grows by 1 millimeter. So by the age of 12, it has reached its full adult size, 15 millimeters from the depth. Every ENT surgeon knows that you have to bury a hole in the McEwen's triangle by 15 millimeters, you will reach the mastoid antrum. Mastoid cells grow at a later date. Next slide. The infant mandible has been enlarged to show the proportion of the head and coronoid process. Remember, you look at the mental foramen in the three. In the newborn, the mental foramen is at the lowest because above that there are roots of deciduous teeth and roots of permanent teeth. In the adult, after the permanent teeth has erupted, the foramen relatively rises, relatively. And in an adult, the upper part is being resolved, teeth have fallen off, mental foramen has gone quite high up. This is what a clinical application that when you are putting up braces of the teeth in an adult, care has to be taken not to damage the mental nerve, which is now quite superficial. Timetable of myelination. Here, I wanted to focus on the first two. The motor roots have started myelinating just before birth. sensory roots take a little longer time to marinate. That means the child can breathe as soon as he is born because the motor roots, and I said earlier, a tract which is due to be myelinated, if it does not get myelinated, it will not function. And demyelinating disease means remove the myelin sheath of different tracts, as in multiple sclerosis. That results in failure of that particular tract to function. Another point to be noted is that look at the fourth one, middle cerebellar peduncle. That develops at around 4 years of age. Middle cerebellar peduncle is for the cortico-pontocerebellar pathway and dentatothalamocortical. This is to smoothen out the act of whatever skillful act you are trying to do. Expecting a child lesser than 4 years to be able to draw an artistic A, B, C is poor knowledge of anatomy. A child gets the control of his fingers and pen only after the age of 4. Only after that, then you can tell a child you are not doing neatly, etc. Not before that. The reticular formation, although it starts much earlier, its maturation occurs only at puberty. And the last one, association areas. When you talk about association areas, you are talking about the higher association areas, which includes Wernicke's, Broca's, prefrontal cortex, parietal association, visual association, and auditory association. All these areas function by around third to fourth decade. That means the wisdom, the maturity, which we say, occur only at around that particular age. Next slide. So, summary, motor before sensory. Next. For axial musculature, medial tracts of spinal cord develop before lateral tract. Medial tracts are the ones which are supplying extensor muscles. Lateral tracts are those which are supplying flexor muscles. So, if a child is born premature, he will show extensor rigidity. If a child is fully mature, then flexor rigidity will come. Because medial tracts are extensor, so premature child will have extensor rigidity. Next slide. For distal limb muscles, especially upper limb, the corticospinal causes hand flexion. Because corticospinal fever flexors, so hand will go into flexion. That's how the child is gripping his hand tight to close. And the only movement which is possible for that particular child is to pick up objects with his hand and take it to the mouth. That's why I said children below 3 years should not be given toys which are so soft and small that he can swallow it and choke himself. There is a warning given. Do not allow this. Next. Next. Associated with the wisdom for the food. It is said, if you want to be very exact, 33 years. At 33 years, the association area is mature. After 33 years, if the person is a crook, he remains a crook, he will not change. That doesn't mean you can't grow any further, but you will only specialize in that particular area which you have done before 33. Next. The vertebral column until birth, the column is C-shaped. It is called as the primary flexion, the position of universal flexion at birth. After birth, the cervical curve opens up to a ventral convexity. When the child holds its head, then when it starts to extend the neck at around 4th month of age, questioning authority. Who has kept me in this particular position? That's also the time when mastoid hair cells start developing because of pull of sternocleidomastoid mastoid. The lumbar curve opens at around 15 to 18 months when the child starts walking. Remember, the child starts running even before that. But when he is running, because the lumbar curve is not opened up, he tends to fall forward. Or he walks with holding the objects so that he doesn't fall. But He can walk properly with the leg posture only after 18 months, when the lumbar convexity has reached its lordosis. The extension of the hip then accompanies walking, tilts the pelvis further forward, so the axis of the pelvic cavity is no longer in line with that of the abdominal cavity. The pelvic cavity, pelvis is a basin, but anatomical position is not like a basin. It's bent forward by around 60 to 70 degrees, and the lumbar vertebra is vertical. There's a sharp lumbar curve which occurs between L5, S1, L4, L5. The spinal cord extends up to L3 at birth. It reaches the ended position of lower border of L1 by around 7 years of age. Next. Development of the lungs. Lung development after birth are divided into 3 stages. Next slide. Stage 1, lasting for birth to around 4 postnatal days. The surface to volume ratio increases. The surface of the alveoli to the volume of the air which it can hold increases. And the surface area increases. So this is because before birth, the pneumocyte type 1, which are supposed to be squamous, they show ridges, they are folded. Now, the moment the alveoli breathe in air, it stretches out and the surface area increases further. Next slide. From day 4 to 3 to 4 weeks, the cells deposit matrix around themselves to fix their new position. Matrix is deposited around the capillary endothelium as well as around the alveoli. Next. The intrapulmonary arteries increase in size and their wall increase in thickness by deposition of type 1 collagen. Before birth, there are type 3 and type 4 collagen in the pulmonary arteries, which are very soft. So now type 1 collagen is deposited, so it becomes a rigid structure. Control of bladder bowel. She and shoe. That's why a person who has no control over his she and shoe is called a shishu. From 0 to 2 years, there is no control of she or shoe, whether he is awake or asleep. 2 to 3 years, he has gained control over the she when he is awake. He tells, I want to go she. But no control over shoe still. 3 to 5 years of age, he has gained control over she even during sleeping. But he has gained control over the shoe only when he is awake. At night, he still urinates. More than 5 years, he is going to have complete control. That's what is described as the normal development of control over bladder and bowel. Again, 0 to different growth curves in different tissues. I wanted to look at the lower one, which is sign shape, which is called as general. Average growth of the body is along the general curve. What you can see here is that at 6 years of age there is one growth spurt, and at puberty there is another growth spurt. And what I wanted to notice is that notice the brain and head. By 2 years of age is almost completely developed. After there is only minimal changes which occurs after that. Myelination continues. But the brain growth in size does not increase much more. The reproductive tract, as you expect, will start developing only at puberty. But what is important is that the lymphoid tissue is high in the pre-pubertal age. By puberty it starts decreasing to its normal level. That means a pre-pubertal or adolescent child has got the greatest reaction towards an allergic stimulus, which occurs right from 5 years to 10, 11 years. After that it decreases. Skeletal and muscle tissue, liver, spleen, kidneys generally follow the growth curves given for the whole body. The 2 spurts which you see, 6 years, 12 years. At all ages, the dimensions of the head are in advance with those of the trunk, and the trunk is advanced with those of the legs. What does this mean? then the head development completes its development earlier than the trunk development. Trunk development completes its growth earlier than the limb development. Limb development continues further. Even there, the upper limb development is advanced over lower limb development. That means the upper limb growth in length is finished earlier than the lower limb. And there also, foot development is earlier than the leg development, which is earlier than the thigh development. The time of appearance of secondary centers of ossification and their fusion with the diaphysis is what determines your final height. So the time of appearance of secondary centers, what's called as epiphysis, and their fusion with diaphysis is as arbitrary as telephone numbers in your phone book and may very well be referred to as and when required. But on an average, you can say that lower limb, the fusion occurs at around 17 to 18 years in females, 19 to 20 years in males. Right? The more distal part of the limb are advanced with the more proximal part. That is, the distal part of the limb stops developing earlier than the proximal part. So as I said, foot before leg, leg before thigh, hand before forearm, forearm before arm. Any questions?